Okay. When do you guys have your test? Is it tomorrow? Thursday? You guys ready? How many questions is it this time? 50? 25?
It's like 50. Wait, she said 20.
Yeah, it should be 25. I took it last session and it was 25 questions. Yeah.
I wish it was 50.
Yeah. So you definitely need to know your strips and know the description of the strips too, because you know, they could have a word problem where it's just describing how like an A flutter looks like it'll be like a saw kind of pattern, like what it is and what interventions which you need to perform with that kind of you know, description. You know, with my class, it threw a lot of people out with that, you know, because all they did was just learn the picture, but they didn't know the description, how the picture actually looked like, the wording of it. So.
She did mention sawtooth.
Oh yeah. Have everyone used a smartboard before? Okay, so you guys know to come up there and move the pictures and whatnot, right? All right. So you would place these on the body. Anyone want to go up and try? You go up and you drag and drop.
Chalkboards.
Thank you.
We didn't even have whiteboards yet.
That nasty feeling at
Yeah,
night.
it's like, oh. But when you got in trouble, you had to clean the
dust. Wow.
kind of aged myself right there. How old are you? Oh man, 24.
No, try it.
It's like I'm almost 10 years older than you, Chelsea. Dang.
I'm over 16 years older than you this year. Get it, girl.
No, it has to be precise.
You have to be precise?
No,
Okay.
well, of course, you know, but that's close enough, yeah. And the ground. In the middle. The ground is always in the middle. Yeah.
Yeah, I thought it was.
Yeah.
Okay.
Yeah, that should be right. So a way to remember this is smoke over fire, cloud over grass, and then the ground in the middle.
So I sat in the middle in class and she said it was on the left. Is it, is it really a big difference?
I was always taught in the middle,
Okay, just,
and I think for this one, yeah. I know what you're talking about though, like how, because there's different kind of leads, you know, some doesn't have all of these, and you just like put it like on the side or something like that. Yeah, so, but for this one, so we smoke over fire, cloud over grass. And then another way to remember this is if you're looking at yourself, you know, white is right, black is left. So that's why if you turn it like this, white is right, black is left. And then cloud over grass and smoke over fire. Yeah. But, all right. You guys want to go ahead and try? So what's the first thing you look at when you're looking at a rhythm strip? Yeah, PQRS. If you can see a PQRS, if it's regular or irregular, if it's a sinus rhythm, or you know, if it's not a sinus rhythm. How do you know if it's a sinus rhythm? Huh? How do you know it's regular? Yeah, P. Yeah, R fits with R. You get like a ruler or a tape measure. You know, you measure these. It's going to be the same. It should be the same if it's a sinus rhythm. The P should align with the P too. So.
So that's the two things that make sure that the sinus is regular and effective anyway.
Yes. Yep. That would be regular rhythm. If it's not, then it wouldn't be a sinus rhythm, and then you can go about, all right, so is this like atrial fibrillation? Because like, say for instance, AFib, you can't see the PQRS, right? Because like the P is like, you know, yeah, it's quivering. It's like a, so what's the first one?
Normal sinus rhythm.
Yep. Normal sinus rhythm.
Bradycardia.
And feel free to come up here and you know, drag it. You guys can't let me do it. Have all the fun. Oh. Yeah. So why is that sinus bradycardia?
There's a P for PQRS,
Mm-hmm.
and
Yep.
it's slow.
Because bradycardia is what? Less than what?
60.
Yeah. And usually what these strips is like a 6-minute strip. So, you know, don't even get caught.
Can you show me how you count to 60? Like this strip?
The strip. So you count the top from the R to R, like so. Yeah, so 1, 2, 3. So that'll be 30 beats per minute. Right. So you'll count the spikes. See what I'm talking about? Like this one, it has only 3. PQRS, there's only 3. Yeah. This one, it has like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Yeah. You times by 10. That's 150. Like that one, you count 3 and then you times it by 10, 20, 30. Why is this supraventricular tachycardia and not a sinus tachycardia? Yeah, so you can't. In this one, you can't really tell if it's a P or a T, right? They're together. And why is this pre-ventricular contraction?
I don't know.
Because there's a beat, there's two.
Premature. So just as the word says, premature ventricular. So in the ventricle, there's a fire in the ventricle before it usually occurs. Like usually it'll be like P Q R S T, right? But it's like P and then it comes, there's fire at the ventricle level. So like let's see, right here. See, this is PQRS is ventricular depolarization, right? So this right here, P, QRS, and then T, and then right before the P doesn't even start over. It's just like it spikes up. That's why it's premature, because there's firing that occurs where it usually doesn't occur. This one actually is supposed to be a P, but it's a PQRS. See, so that's how you tell it. These are normal right here. See, P, QRST, and then P, QRST, P, QRST. Then right here, it fires before it should. After the T, and then it's like QRS. It doesn't. You don't even see the P. Yep. So what happens? What causes that? Yep. And also magnesium too. Like those are the main ones, but electrolytes imbalance can cause that as well. So with that, how would you fix it?
You correct the electrolyte imbalance. You correct the electrolyte.
Yes. As soon as you fix that, it should fix the problem. So
how do you know if it's atrial or ventricular?
how is it atrial? Okay. So if it's atrial, then the premature atrial contraction. So it will happen. There will be like two lumps at the peak. Yeah, it'll be like it won't be like this. See this clearly, you can see that it's PQRS. Atrial contraction probably won't be this high. Yeah, and we'll probably get to it too.
So that's called PVC, and that's because the
Hypoxia and hypokalemia or hyperkalemia. All right. All right. So what's the first one?
Atrial flutter.
Atrial flutter? Why is that? Well, first of all, like, is this strip considered a sinus rhythm?
No.
Why not? Yeah, so you can't distinguish between the PQ or S, because this one is just like a whole bunch of waves, right? So is that regular or irregular? Why is it regular? Yeah, so from the R to the R, it's the same. However, you can't really measure from P to P, right? Why? Why can't you measure from P to P? Yeah, you can't really tell what's a P or what's a T. So you can't do that, but you can measure equally from the R to R. R, yep. So the first one you guys said is what? And make sure you guys go know how the wording description of this is. Like I told you, it's very important. It's going to come on the test. Like there'll be a description. Oh, a patient comes in with like heart rate of 190 and like with these waves, with the saw tooth or whatnot. And if you never learn the description of these strips, then you'll be like, what are they talking about? Because this one, you might think it's this one instead of this one. So this one is like, I can't remember the description of it. Have anybody read on AFib, how the description is?
Yeah, I think of it as like mini but sharper.
Yeah. I just know that that's sawtooth, and if there's any other description, probably this one. So, but I can't remember the exact description for this one. How it's like, again, it's like really. But is this one regular or irregular?
It's irregular.
Irregular. Yeah. Why?
They're not distinguished.
Yeah. So if you guys can see from here to here. Oh, from here to here. It's different from here to here, right?
Yeah.
I need to recalibrate that again. Yeah, so from this distance, from here to here, it's different. This one is wider, see? So when it's regular, all these should match. All these should be the same length. Okay, no, yeah, R to R should be the same. This should be the same with this. But obviously this one is longer than this one, see? So, what did we say that one was? AFib. My bar's not working this morning. Okay, so what's this right here?
Type 1.
And why is that?
Because the P's are greater than the QRS.
It's a lot longer, right?
A lot longer.
Yeah.
Yeah.
It takes a lot. It's just a lot longer. It's like your heart's beating. It's like boom, boom, love, dub, and then like kind of like really slow until it beats again, love, dub. You know, which a regular heartbeat is like love, dub, love, dub, love, dub. But this one's like love, dub, love, dub. You know, so it's a lot longer. So PQRS, T, right? And it just pauses. You know, and then it's like there's a I guess P, and then it goes again, and then it's P, Q, R, S. T, P, Q, R, S, T. It's just like a really long pause.
So which one is that type?
I'm thinking this type,
Two.
No.
yeah, I'm thinking this type, because I mean, it's right here, there's an extra P, and it doesn't go off, right? So it's like, there's probably a P right here too, and then
Type 2
Q, R, S.
has, yeah, more P's.
Yeah, so I think it's type 2. Because I know type 1, it's just like slow.
Would
Right.
it be three?
I think
because
it's
QRS is
QRS,
wide.
QRS, yeah.
Oh, let's try it. Because 3, it would be,
3, they wouldn't.
yeah, it
there would
wouldn't
be no
be
relation.
anything. Yeah, it wouldn't be anything. I think it might be, let's try 1. I think this activity like needs fixing, yeah. So this one is probably, I think it's 2. If anyone want to check it, because you know there's a P and it's not going. There's no QRS. Because type 1, it's like slow, right? It's slow, and then it gets slower, right? The type 2, it's like it's slow, and then it drops or something, right? And then it goes back to normal. So this activity, this thing, I just remember you gotta fix it. Yeah, so let's try to do this one.
Yeah, that one's type 2.
Yeah. T, P, Q, S. Yeah. Yeah, this one is type 1, right? Because it gets longer, or it might be, yeah. Yeah, second degree is type 1. Yeah, because it gets progressively longer. Or this one, it drops and then it comes right back. This one has to be,
The top one's third degree.
third, yeah, that's what I'm thinking. Because I mean, it doesn't flare up.
Yeah.
Yeah, this one. degree. It's just longer, right? First degree is just a lot longer.
Yeah.
Yeah. So that one, gotta remind myself to fix that one. So we'll just put this right here just in case you guys want to take a picture. Oh, it goes in. Yeah. So. So just to go over that one again. So what is a first degree block? How do we know when it's a first degree block? Yeah, 0.2. It gets, yeah, it's a lot longer. See right here, P, QRST, and then it's like longer than a normal sinus rhythm. With this kind of condition, do you have to really worry about the patient?
No.
What do you do? Monitor them, right? All right. What about this one? Type 2, second degree. What was that?
More P's and QRs.
Mm-hmm. Yeah. So it's long. It gets long and then it drops, and then it goes back again. Right? It's like progressively, longer. So this is, this starts with T, P, Q, R, S. It's normal, P, Q, R, S, and then it goes T and then P, and it stops, and then it goes, right? So that's how you determine a second degree type 2 block, because it's normal, and then it suddenly drops, and then it goes back to normal. And then this one, like the next part should be kind of similar to this right here. See how it's like P, Q, R, S, T, and then T is right here. You can barely see the T as well. And then it will probably go pause for a bit, and then it'll go back to normal. If this strip right here were to continue. What about second degree type 1? Progressively longer, right? Yeah. It's not going to have a pause. It's just going to be long, and then it goes back to normal. So P, Q, R, S, T, and then P. See, it's a little longer than the first time around, right? And then P, Q, R, S, T. And this one is even a bit longer, I want to say. Well, this one is way longer than these. And then it goes back to normal. And then it's going to continue to do that. What do you do with this patient?
And if you need to give acid, you give it.
Yeah, if it starts to become really slow, then you do. But you also monitor, and this patient might need a pacer as well, because over time it might get worse. Because with this condition, it's the heart pumping efficiently. No, right? Because it keeps pausing. So usually you want your heart to be consistent, right? Pumping blood into your body. And then, okay. What's the magnesium one? Yeah. So how do you, what's going on in this patient? Do they have too much magnesium or low magnesium?
Low magnesium.
Yeah. So what do you do to treat that? Yeah. Give magnesium, and they should correct that problem. Which one is a systole? Yeah. What do you do when a patient, you walk into a room, patient's laying on the floor, you feel they're pulseless, they're not reacting, you're telling them to wake up, they're not talking back to you. What do you do? TPR and what? Do you defib them?
No.
Why don't you defib them? Yeah, there's no rhythm. The only time you defib really is when you start seeing a rhythm, like a crazy rhythm, like this guy right here. And then you. Okay, so with defib, when you're defibbing a patient, is it synchronizing with the QRS?
No.
Which one is that one?
Part of the version.
Yeah. So when you're defibbing someone, you're just shocking it so it can stop and then it goes back to normal, right? You reset it. So why is it that in the movies, usually, you see a person fall out, and they're giving CPR, and they're pulseless, and they give CPR, and then they pull out the defib and they defib the patient. Why is it that?
Was it a movie, not real life?
No. In real life, it happens too. So what do you? Yeah, they got a pulse back. So that's the reason. When you're giving CPR, you're pushing epinephrine, getting the heart to come back, you're going to get a pulse. But then that pulse might be out of whack. It's not going to come back like normal. Sometimes it comes back normal, like, normal sinus rhythm. But there are times where it comes back and it's just like, because the epinephrine, it speeds up your system. So it's just like crazy. So that's why they defib them to get it back normal. That's the only time when they defib. But on the test, it's usually CPR and epinephrine. Don't do the defib, right? What's this one right here? V-Tach. Can you tell if there's a Q or S?
No.
Can you tell if there's a P or a T?
No.
Yep. So this is why it's not a sinus rhythm. So when you determine it's not a sinus rhythm, it has to be something else. And this is V-Tach because you can kind of see that it's QRST even though you can't really tell. But usually P waves or like T waves, it's like a lot smaller. But this one is just like really big, so that's why it's called ventricular because it's happening in the ventricle. And usually we know that the ventricle is a QRST, right? So what's another word for this one? Tombstone, yeah. So in this situation, what do you do? Do you cardio conversion? No.
If they have a pulse.
So most likely, usually in a situation with V-Tach, they're not going to have a pulse. It's so crazy where, their heart's beating so fast, you're not going to even feel the pulse, So, and you're so limited in time when it comes to V-Tach. If you don't defib them right away, there's chances where they're going to go into a systolic. So that's why there's that mnemonic where it's like if it's V-fib, wait no, I got it mixed up. It's V-fib and you defib. But V-Tach, you want to, okay, so as I recall, V-Tach, if it's greater than 180, right, that's when you want to treat it with amiodarone first, right? Is that right?
That's A flutter.
Less than 180 is.
Less than 180 you want to do with pharmacol.
That's with A flutter.
That's where it's like 180. 180 is when you want to do amiodarone, but not the dead man's dose though.
If it's less than 180.
If it's less than 180,
You're gonna, if it's less than 180, you're gonna do the amiodarone. But if it's greater, that's the cardiovert.
if it's greater than 180, you
And
cardio.
cardiovert, if it's
cardiovert.
less than, then you're gonna give amiodarone or.
You guys positive about that?
Yes.
Someone looking in their notes?
No.
You just know like that. Okay.
When you have a no pulse, you call it totally
Yeah.
Or when you have a pulse, you're
Yeah. So if it's pulseless, then you do it as a code. Yeah. Uh-huh. Yeah. Without a pulse, CPR, and then you defib,
With V-Tach, you're gonna,
epinephrine,
yeah.
and amiodarone.
Yeah.
With a pulse, you talk to a cardiologist, synchronize cardioversion, put them on sedation, 50 to 100. Okay, so that's what it is. So with a pulse,
in a shop.
So if they have a pulse and you'll refresh my memory. Is this one do they go about this one with like they show signs and symptoms versus they don't show signs and symptoms? Is this the one too?
I'm sorry?
If they show signs and symptoms. You know how like in cardiac
if it's
conversion there's
symptomatic.
elective and there's non-elective,
Yeah.
right? So would this situation be non-elective or elective?
I didn't know those terms.
You know what I mean?
So elective.
Yeah. Because elective sometimes they can have like a like a dysrhythmia, but they'll show no signs and symptoms.
Do you mean like asymptomatic and symptomatic?
Yes.
Okay.
Uh-huh.
I thought it was for like, I thought it was like if their sinus breathing. Then you treat.
That no
Or
tachycardia.
Are you
Yeah.
asking us what do we do if they're in V-Tach? Is that what you're asking?
No, I'm asking like, is there a situation where they will have elective or non-elective?
Oh.
Because like I'm looking at my notes right here. Yeah, because I'm looking at my notes right here and it says ventricular tachycardia, and then it says with the pulse you'll go to your doctor and ask for like consultation.
I just had that if you just need to determine if the patient has a pulse or not, because that determines if you defibrillate or not. That's all.
Yeah, that's what she told us.
Yeah. So if they don't
because
have a pulse.
because in my notes it says with the pulse you do synchronized cardioversion. Yeah.
Well, if it's greater than 180,
Yeah.
it says you do cardioversion, and
Uh-huh.
then it says.
So
if-
without a pulse you do
without a pulse,
defib.
Yes.
Okay. So just,
And if it's less than 180, you do the amnio.
Is that still the
That's
same
what
in
it
V-Tach?
said.
I don't see greater than 180 in my notes. You don't?
Yeah.
Yeah. So I don't have greater than 180. I don't.
I only have that for atrial and A flutter. Yeah. It's
Yeah.
only that for AFib and A flutter.
For
Because V-Tach with the pulse.
what I dictated or transcribed from her was that treatment is shock. If pulseless, you're gonna do cardioversion, or pulse, you're gonna do
You did.
cardioversion.
Yeah.
Pulseless CPR,
Mm-hmm.
and you're going to do.
Yeah. So without a pulse
amiodarone and
CPR.
lidocaine.
You're right, because you would.
Because if there's ventricular tachycardia without a pulse, we go back to this situation where it's assisted. Why would you defib? So you do CPR first, and then you get the rhythm going, and then you defib. Yeah. So just to put that out. Yeah. And then amiodarone at the end. Yeah. So just to go over that again. Ventricular tachycardia, they have a pulse, then what do you do?
If they have a pulse.
You do have, see, that's the thing. Okay, so do you do amiodarone if they have a pulse?
Yes.
You do it.
Yes.
And then you do cardio conversion. If it doesn't work.
Doesn't work.
Yeah.
Gotcha. So amiodarone is always first because it's that less invasive procedure, right? So amiodarone, and then you do cardio conversion.
Yeah.
Cool. And then if they have no pulse,
Then you do call the code, defib.
call the code.
CPR.
No,
Call
you
the code, do CPR, and then
And then you get pulse.
yeah, until you get a pulse, that's when you defib. Yes.
I'm a little confused because, you said if there
I know.
is pulse
Uh-huh.
and
Or no.
No.
No, you
and
won't.
then you do,
Yeah.
You don't shock
and
them.
then we'll do.
Okay. So if they have a pulse with ventricular tachycardia, if they have a pulse, you want to try amiodarone first. Because you always want to do the least invasive. So amiodarone, and then if that don't work, then you do cardio conversion. Yeah. Yeah. Because with this one, I guess you know that.
Pulse. They don't have a pulse.
Because like with cardio conversion, remember how I was going about it synchronizes with the QRST, and I guess this one you can see the QRST, you just can't see the P and T, because it's big waves. So with that situation, that's why I guess you would do cardio conversion, because it synchronizes with that, and then it'll make it go back to normal sinus rhythm. Yeah.
I don't say amiodarone for pulseless.
For pulseless?
Yeah.
No.
I can do without a pulse.
Yeah, so in my notes, I don't see amiodarone with a pulse.
But why wouldn't you do it if you have a pulse? Because the whole purpose of amiodarone is to take it from an irregular rhythm to regular.
Yeah.
Like, that's its purpose.
Yeah.
So why wouldn't you?
You know, I
Can
can see that as
So
well.
basically, if you have V-Tach, you're gonna go in, you're gonna see your patient
Mhm.
on, basically,
Yeah.
going through some stuff. So you're gonna assess your patient.
Yeah.
If they don't have a
Go.
pulse, if they
Oh,
don't
we're
have
gonna
a
be going.
pulse, then you give CPR,
If they don't have a pulse.
right?
Yeah.
Everybody with me?
Yeah.
Yes.
Okay.
If they don't have a pulse, then you give CPR.
Mhm.
And then, once you get that pulse, then you shock them.
Yeah.
Then, epi. No?
No.
No, you give
epi
epi
first.
before that. You give
Okay,
epi
so,
before that.
okay, so here, we assess,
Uh-huh.
CPR, epi, shock,
Yeah.
right?
Uh-huh.
Yeah.
Yeah. And then it does say amiodarone without a pulse. Yeah. At the end. You guys looking at? You guys have?
amiodarone after that.
Yeah. Amiodarone after that. But it
Okay.
wouldn't be a dead man
But
dose.
you have to,
Just one pick.
epi and
Yeah.
amiodarone alternate.
And if it doesn't work, then you you keep on doing it, so you can give epi every 3 minutes,
Yes.
Yes.
Yeah.
right?
Yeah.
Okay.
And then amiodarone.
She's
Huh?
like, wait. I'm confused. Let's wait with it.
CPR. CPR. No, so you give CPR first. See how it says CPR? And then you give the, when you get a pulse.
Like pulse
CPR, CPR. But it's probably not in that order though. Because I mean, if you think about it, it would make more sense if you CPR and then epi to bring back the pulse and then you defib because they're supposed to be irregular. Yeah. But I would ask her, any questions that, you know, we discussed in here that, just like that one, I would ask her again in class today, just to clarify it. And then one of you guys come and tell me about it, because I want to know. Alright, so what's this one right here?
No, he said,
That's
that's
V-Fib.
V-fib. So when you if they have V-fib, what you do? You defib. Yep.
V-Fib.
So.
I was like, how do you guys even see that option?
No, I'm just like this. That's
So yeah, so how do we know that this is V-fib?
It's just
It's just
Yeah.
V-Fib.
It's really fast. You can't really tell where the P or the QR, you know, QRS is not a normal rhythm. You can't really measure it. So it's not sinus rhythm, so it has to be something else. And it's just really